Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Mr. Chairman, for this introduction. First of all, I would like to thank the organizing and scientific committee for inviting me to be with you. I'm going to talk about a very difficult topic, so give me time to explain the concept which is needed to be applied in our practice. So I have been assigned to difficult to treat spondyloarthropathy, and first of all, I have no financial disclosure or conflict of interest. And this is the objectives of my study. Is difficult to treat concept in RA similar to spondyloarthropathies or no? And what's the best approach in a patient with difficult to treat spondyloarthropathies? So first of all, we have to keep in our mind that less than 20% of spondyloarthropathies patients achieved remission over a year and a half. And 1/3 of patients on biological therapy achieved low disease activity over 1 year and a half. And looking to the cohort that include very large number of patients, around 6,000, around 14% of patients still require to be treated by more than 3 biological agents or targeted therapies. This illustrates how the disease is difficult to be controlled, and we have now to explore the definition of difficulty and refractory disease. So please, you have to differentiate at the end of my talk between difficult to treat versus refractory to treat. I will try to explain it in details. First of all, difficult to treat are associated with some risk factors. If we have female patients, and as Professor Zam before illustrate, female patients, they do not respond well as male patients. Smoking, obesity, depression, psoriasis are all considered risk factors for difficult to treat. Females, they do not respond to the anti-TNF agents as good as male. So if you are starting your patient anti-TNF, expect or keep in your mind difficult to treat aspect. Obesity, and the story of anti-TNF. There is a meta-analysis, excellent paper published, I think, 2 years ago, indicating that obesity is a risk for non or inadequate response to anti-TNF agents in spondyloarthropathy as well as RA. So if you have obese individuals, you think about different mechanism of action. Depression and anxiety and psychiatric manifestations are factors to increase the likelihood of difficult to treat. Now back to the objective of my talk. It has been presented earlier, the difficult to treat concept of rheumatoid arthritis. And let me explain to you why when we talk about spondyloarthropathy is different. First of all, difficult to treat concept has 3 criteria. I'm going to explain to you why it's not applicable in axial spondyloarthropathies. First of all, in RA, you have to have a patient who failed minimum 2 biologics after synthetic DMARD or traditional DMARD. What's the role of traditional DMARD in axial SpA? Probably no rule when we talk about axial SpA. And then the second one is the steroid. What's the role of steroid in axial SpA? In rheumatoid arthritis, it's one of the criteria that the patient has to be failed to be tapered less than 7.5. What's the role of steroid in axial SpA? No rule. Now, the third important point in definition of difficult to treat concept rheumatoid arthritis is the rapid radiological progression with or without evidence of active disease. In axial SpA, the progression is not as quick as RA. And this is a very important slide to all of us. Now, when we talk about the axial SpA, we use the ASDAS as a tool for the assessment of the disease activity. Now, let me point some important point. ASDAS doesn't contain all the manifestation of axial SpA. Where is enthesitis? Where is dactylitis in the ASDAS? The other important point is the extra-articular manifestation. You might have a patient with active uveitis, active IBD, inflammatory bowel disease, where I and you, will change the management, while DAS might be in remission. So this assessment tools is not like DAS28 in a patient with rheumatoid arthritis. And yes, there is an evidence, relatively is good level of evidence that support the limit or the numbers that indicate the disease activity by applying the ASDAS. Less than 1.3 is remission, less than 2.1 is low disease activity. But who is changing the biological therapy based on 2.1, not 2.2? Nobody. And actually, looking to the literatures, they report the real-world data or observational studies. Most of the rheumatologists, they change the biological therapy when the ASDAS scored 2.5 and above. And therefore, can we use it? The difficult to treat concept using ASDAS probably is not like rheumatoid arthritis. Now, if you remember the concept of rheumatoid arthritis, they indicate the inflammatory markers. The inflammatory markers in axial SpA, whether ESR or CRP, are elevated in only, and again, only 50% of patients. So half of your patients, they will have active disease despite they have normal inflammatory markers. Who is doing MRI routinely? I think none of us. And therefore, MRI is not routinely recommended for monitoring the disease. The structural damage, it takes long time to be there. And it might be up to 2 years. And if you look to there are recommendations, they recommend to repeat the MRI after 2 years. Are you going to wait for 2 years to change the treatment? And that illustrates the difficulty of applying difficult to treat concept of rheumatoid arthritis into axial SpA. And I found this is an extremely important to all of us, residual disease concept. Residual disease, you have a patient who is in biological or targeted synthetic therapy, despite that they have some pain. And this pain should be elaborated as residual disease activity. And if you look to the EULAR recommendation, residual disease activity doesn't need to intensify the therapy. It just needs to be controlled by analgesia, whatever the type of analgesics is appropriate for your patient to control this disease or residual disease activity. Your patient might have a pain not at all related to the inflammation. It's related to the secondary damage due to osteoarthritis or chronic pain mechanisms or conditions. Comorbidities. Always think about fibromyalgia. They are not uncommon in axial SpA. And some of us, as Prof. Suzanne illustrated earlier, might change treatment unnecessarily. That change is only based because of fibromyalgia. And your patient is unhappy, he has pain. This is not a SpA. This is not an active spondyloarthropathy. And then when we look back to rheumatoid arthritis, we have to go in deep about difficult to treat rheumatoid arthritis. Two types, PIRA and NERA. And PIRA, that means the persistent inflammation in a patient with active rheumatoid arthritis, where there is an evidence of inflammation, high CRP, ESR, arthritis, synovitis, and imaging. In NERA, there is lack of inflammation. Pain is there, yes, but there is no evidence of active inflammation. It's related to the either autoimmune or neuroinflammatory pathways that independent of joint synovitis, so don't change or intensify your treatment. And therefore, this takes me to the new concept. We all talk about difficult. What's about refractory? What is important to me and to you is refractory rather than difficult to treat. So refractory, when there is an evidence of inflammation, here you need to change the treatment. Here you need to think about the biological therapy. While difficult to treat, it's because of the other mechanisms that affect the pain and the reception of the pain into your patient. Quick touch to TCOPSA trial, which is the only RCT that evaluates treat to target in axial SpA, whether this affects the difficult to treat patients outcome or no, and they found, as you see, they did not meet the primary endpoint. And therefore, if you have difficult to treat patient, please think several times before you change the therapy. Difficult to treat, is it associated with bad outcome or no? We don't know at this moment. Yes, there are several observational studies that indicate we have to think about treat to target, but again, what is your target? And that study they use, why I like it, because they use the health index where there is PROs, patient-reported outcome. There are a lot of talk about it. We can discuss it. If we are using ASTAS, it met the secondary endpoint and so on. But anyway, if you talk about the patient-reported outcome, it didn't meet the primary endpoint. Now, PSA is even more difficult than axial span because of several reasons. Multiple domain. You might have a patient who is inactive in peripheral arthritis, but they are active axial. They are active enthesitis. Axial and axial, majority of people think it's not common, but that's not true. It depends on the duration of the disease. If your patient is lucky early in the course of the disease, the patient might go as low as 5, but it's ranging between 5 to 20. If your patient has disease more than a decade, the prevalence can go as high as 70%. Use of MRI and ultrasound are not routinely used to assess the inflammation in the clinics. And this is very surprising to me, at least. Inflammatory signals can be there in image in a patient who is clinically in remission. And then, are you going to change the treatment? I don't think it's easy, but I wouldn't change the treatment based on only imaging finding. DAPSA and MDA. We're all saying use DAPSA or MDA, and we cannot use it in our registry in Saudi. However, a lot of limitation for this assessment tools. DAPSA doesn't contain enthesitis. It doesn't evaluate dactylitis. It doesn't evaluate skin. So anyway, if you have difficult to treat PSA, always think about these things: fibromyalgia and fibromyalgia, non-adherence, comorbidities, degenerative disease, and so on. So difficult to treat, please, before you change the treatment, think about the two terminology: difficult to treat or refractory to treat. If it's refractory to treat, change. If it's difficult to treat, think several times before you change the treatment. Now, back to the objective of the talk: is it the concept of RA applicable into the spondyloarthropathy? When we look to the PSA, again, what's the role of synthetic DMARD? We don't know. Leflunomide has only 2 studies, and all of them are not RCTs. Sulfasalazine has only 1 study. Methotrexate, a lot of studies, very contradictory data about is it DMARD or is SMARD? And it's very good as a SMARD. DMARD, it's questionable. And therefore, am I obliged to use methotrexate as DMARD to say this patient failed or no? We don't know at this moment. No role of steroid for PSA and PSO. And therefore, maybe is not applicable, the concept in a patient with PSA. Radiological progression, rapid in RA, that's not story in patient with PSA. And therefore, again, ultrasound, MRI, not used routinely for monitoring of PSA. As I said earlier, inflammatory signals can be there while your patient in remission. Radiological progression is not a story in a patient with PSA. And a very important questions that come in my mind while I prepare the talk: remission, is it dynamic or static? Are you happy when your patient at this moment in remission, or you will be happy when the remission is sustained? And we don't know. What's the difference in the outcome for your patient? And therefore, again and again, it's very important: difficult to treat or refractory to treat. So to summarize it, difficult to treat, presence of the associated factors or comorbidities, and mainly and namely fibromyalgia. Refractory to treat, your patient is having an evidence of activity, either inflammatory markers or imaging and clinical manifestations that indicate the disease activity. Why this is important? Because this scheme has been proposed okay, recently, when you have such patient. Always think, does your patient having reasons related to him or herself? And if it's this story, this is difficult to treat. If the reason for non-response relates to the disease itself, i.e. high inflammatory markers, imaging, active synovitis, here think about the management and changing the treatment. And this is, I found it's very important. We have to think about what is the best approach to our patient. So difficult to treat, no clear evidence of disease activity. Refractory to treat, there is an evidence of disease activity that supports your decision in changing the management of your patient. And I found this study that's recently published is again very important to our topic. Difficult to treat. Do I need to change the treatment? This study indicating that the difficult to treat, even when they are associated with comorbidity, it doesn't appear to be associated with increased risk for the major cardiovascular events or death. And then, do I need to change the treatment? If it doesn't associate it with increased risk of death and mortality, this is again, it's a hot area to be covered in the future. So difficult to treat in a patient with comorbidities, obesities, fibromyalgia, long time from diagnosis to first biological therapy is associated with increased the likelihood of difficult to treat patients. So in conclusion, difficult to treat axial SpA, we are seeing it in the clinic. It's more common in women, more common in patients with peripheral involvement, more common in patients with severe psoriasis and comorbidities. And then it's a very important question. Yes, we have some evidence that it does not increase the risk of mortality, but still it's an area for research, and it's very important because this will help us in the future. Is difficult to treat axial SpA associated with increased risk of cardiovascular and mortality? And at the bottom line, there is no consensus definition of difficult to treat axial SpA, difficult to treat PSA. And I would like to draw all of us, attention, all of us, that there is a difference between D2T and R2T, difficult to treat and refractory to treat, because this is really very important. We don't want a quick change of the treatment. You don't want to lose the response just because your patient is having fibromyalgia. Always, please, always think about improvement, the quality rather than the number, as that's 1.1, 2.1, 2.2. That's good for research, but for your patient is a quality of the life, and avoid harm. Don't intensify treatment unnecessarily. Thank you very much.